Who's
Hello everyone. I welcome you all to the session of Indo-American Society of Nuclear Medicine Radiant Flashpoints educational web series titled Transforming Healthcare: How AI is Reshaping Current Medical Workflow. Today we have two eminent speakers with us, Dr. Mamatha Chivukula, MD, FASCP, and Dr. Kishore Dhara, Ph.D. with us to enlighten us on this topic. Dr. Mamatha Chivukula serves as Director for Breast Pathology Services at Mills Peninsula Medical Center and holds medical staff appointments at San Mateo Medical Center, Mills Peninsula Medical Center, El Camino Hospital, and Sequoia Hospital in San Francisco Bay Area. She has extensive experience in multidisciplinary diagnostics and molecular aspects of cancer diagnostics to ensure high quality in women's health services. Dr. Chivukula held academic position as Associate Professor of Pathology at Magee Women's Hospital of UPMC Pittsburgh, rated top 7 in US for women's cancer hospitals. Her collaborative research work has yielded 50 plus publications, 100 plus published abstracts in leading journals, and she has also co-authored several book chapters. She served as Education Director for prestigious ASCP organization and serves currently on Sutter Anatomic Pathology Education Committee and continues her active research. She serves on Senior Scientific Advisory Board for pharma companies like Merck and AstraZeneca. Outside of her professional activities, Dr. Chivukula is a trail half marathon runner and has been part of coastal trail runs for 12 years. She also participates as a volunteer for SMMC Walk with Dog program every year. I welcome you, ma'am. The next speaker, Dr. Krishna Kishore Dhara, is a recipient of Thomas Alva Edison Award for Innovations in 2015 R&D Council, New Jersey, USA. Dr. Dhara is currently the Chief Innovation Officer at Bourntec. He is heading the AI/ML globally at Oaknorth, a UK-US based fintech unicorn. He did his PhD in computer science from Iowa State University. After PhD, he joined Bell Laboratories in New Jersey and worked as a senior research scientist before moving on to his startup journey. He worked as CTO for several startups both in the Silicon Valley in the US and in India. He's an advisor to several tech and life sciences startups. Dr. Dhara has authored over 25 refereed ACM, IEEE, and other publications, and he is part of several IEEE ACM program committees, acted as chair to several special research sessions, and is an invited speaker at various conferences and events. He holds around 35 plus US and international patents and authored several book chapters. Dr. Dhara is working in AI and ML in the field of various disciplines such as healthcare, finance, life sciences, and telecom. I welcome you, sir. I request the speakers to initiate the session.
Thank you very much. We are definitely humbled by your introduction. Dr. Dhara, would you be able to share the presentation?
Let me know if you can see. Is it good?
Yes, but I haven't seen. Oh, okay, perfect. So in context of time, I am going to be jumping into the agenda, which is the next slide, if you don't mind. So Dr. Dhara, would you be able to, yes. So basically my talk is going to be focus more around the current workflow system, what we have particularly for the cancer care. And the second part of the talk would be about the introduction of the artificial intelligence, AI, and how is it going to reshape reshape the current workflows. And finally, our thought processes, conclusions. We will be able to take the questions at the end of the session. So with that, can you move to the next slide? So practice of medicine, particularly the cancer care, is becoming more data-centric and patient-centric. In the era of personalized medicine and rapidly advancing cancer therapeutics, the role of pathology in the diagnosis and management of cancer is evolving. Pathologists and radiologists have become the major stakeholders in cancer care and decision-making. Pathologists are drivers of optimal workflow organization in fast-changing practice environment. The workflow organization in pathology labs is not a topic that's well understood as of now. So, next slide. So so basically, I think Dr. Dhara, you have my old presentation. Ruchi, would you be able to share my new presentation? Or so I'm sorry about it, but I think I do have.
That's the last copy.
I made some changes in my
Yeah.
presentation, so I
Just a
am
minute.
going to be working on my stuff. So sorry.
Is there a chance you can share it yourself, or?
I did share it with Ruchi, the presentation, but that's okay. She had a problem with.
I can share it. Just give me a minute.
Okay, perfect.
Sorry about
That was the last one I had. Sorry about that. I thought that is the that's the version that you wanted to use.
Oh no, that's okay. I should have told. So, all right. I think she is. All right. It's awesome. Is that my presentation, Ruchi?
Yes.
Ruchi, you'll have to advance the slides and maybe go to slide.
Yeah. Can you please do that? Okay.
Is it good?
Okay. So that's fine. I'm good. Okay. So currently, we generate pathology reports with enormous amount of data. So the point is, like, I'm very lucky to be trained in the era of where the reports are at least 3 to 4 pages. And now it's increasing day by day as the biomarkers are increasing. The pathology report, we can extrapolate many things for the cancer patients, particularly selection of patients for chemotherapy, eligibility for radiation treatment, prognostic data, clinical trial eligibility, especially for patients who do not respond to standard treatments. The recent advances in targeted therapies, molecular biology, and immuno-oncology necessitate a closer integration and coordination of the pathology with the multidisciplinary cancer care team. Currently, there are no established criteria to classify the levels of integration between pathology and multidisciplinary cancer care team. I know that speaking to a lot of my colleagues across the world, and through my experience, I can say that some of the countries have established this multidisciplinary cancer care team. And in some countries, it's still a work in progress. So next slide, please. So I thought that when you Google the daily workflow, there are many models that come through from the Europe, from America, and other places. So I thought that the case-based learning of what we do every day can help us to understand how the workflows are so complex right now. So I'm going to be talking about our cancer patients and how our workflow begins and goes on. Case 1 is a 65-year-old man, smoker, 40 plus back years, presents with lung mass in the right upper lobe. When I talk about the specimen that I received in the pathology lab, things have changed because as the more minimally invasive laparoscopic ionic bronch specimens are coming and the less invasive procedures are being done, we do receive multiple specimens on lung cancer specimens, which are fine needle aspirations, a cryobiopsy, ion bronch biopsies, or forceps biopsies. So we do get multiple specimens. Part of the reason is that our pulmonologists are trying to understand what would be the best yield with minimal procedures. So our workflow begins with diagnosis on the slide and the use of immunohistochemistry. And it is challenging in terms of IHC because you do not want to waste the material. So we do have the challenge of triaging 3 cell block materials. And we have to follow the guidelines from ISLAC, ATS, CAP, ASCO guidelines. So first thing goes with a call to the interventional radiologist, discuss what do we have, a non-small cell carcinoma or a small cell carcinoma. And after that discussion, then another call goes to an oncologist who is dealing with the patient care. So there goes the most important things are the biomarker testing. Every lung cancer patient, particularly the non-small cell carcinomas, do get biomarker testing here, which are the 4 important biomarkers: EGFR, ROS, ALK, and PD-L1 for immunotherapy. So when I say the biomarkers very easily, I will show you an algorithm of how we started our workflows. And right now we are in a great situation that we do reflex biomarker testing, and PD-L1 testing is done in-house. And then the question comes, the next generation sequencing. That's opted for selected patients. Next slide, please. So, Richie, and next slide, if you don't mind. So this is a comprehensive report of an NGS lung report. And I know there is a tumor type, which is colon cancer. I just wanted to show how colorful the report is, about 5-6 pages, okay? But again, these are the reports scanned into the patient's charts as well. On the left side is the current patient, and the reports have gone through a lot of changes, and important information is put in the front page, then goes and others and others and others. So part of the therapeutic implications are part of the report, where we see the molecular alterations, a deletion and insertion, and what are these patients eligible for certain clinical trials? So there is a lot goes into the next generation sequencing testing report. Next page, please. So I just want to share an algorithm. We started off something developed by me with the multidisciplinary teams, cancer teams here in 2013, trying to understand how we can process the lung specimen and how we incorporate the molecular testing and the immunotherapy testing, which is the PD-L1. So many of these parts of this molecular testings are all like contact your oncologist, contact your radiologist, all that stuff. But now, fast forward, we have come to a standardization of what we want to do and what we want to discuss with and when to discuss with. Some of these are reflex testing. Can you, next slide, please. So these are all part of this. I developed it, but I am happy to see, fast forward in 10 years, that we have made a lot of progress. So next slide. Case number 2, a huge molecular things are happening within the breast cancer field. So a 55-year-old presents with calcifications on a routine screening mammogram, and stereotactic guided core biopsy is done. A moment a woman comes into the breast cancer care and screening mammogram or anything, I'm highlighting which is the turnaround time. So that's a huge thing for us, turnaround time, patient care, personalized medicine. So 24 hours is our turnaround time for every cancer report. And if it involves immunohistochemistry or anything, it would be 48 hours. So that's where it's really get important and stressful for the pathologist. So this patient is diagnosed with ductal carcinoma in situ. You can see a nice histology diagram of it. And we do immediately report the biomarkers, which are estrogen and progesterone, which are very important for the treatment. Next slide, please. So then I just want to bring to your attention the explosion of genomic testing in the area of breast cancer. And that's what we have to deal with. And every DCIS patient, the radiation oncologist or the oncologist calls us and requests for something called Decision RT. It's marketed by Prelude. And what this test is, interestingly, it is developed by the pathologists. And I'm happy to say that my former boss from University of Pittsburgh is involved in this. So the Decision RT test quantifies risk of recurrence in these patients, and radiation therapy is beneficial for these patients. I think at this point, I want people to understand what a ductal carcinoma in situ is, and to a patient when they are diagnosed with it. It is really stressful for a woman that the first question she would ask is that, how is it going to come back as a cancer? What are the chances of me living? And all these questions do come, and it is pretty stressful. So we do have the Decision RT to tell, and also the biomarkers to conclude the prognostic features of this patient. Next slide, please. Another case scenario, 65-year-old woman comes with a 2.5 centimeter breast mass in the lower outer quadrant. Again, I did mention the turnaround times, and a mammogram finds a nodule, and this is what a breast cancer looks like. And immediately we do have the biomarker testing. The reflex biomarker testing for every breast cancer is estrogen, progesterone, which are very important for the hormonal therapy. Ki-67, I just want to mention a nice anecdotal thing, which I can never forget. When I was a junior staff at University of Pittsburgh, a radiation old-timer radiation oncologist asked for the Ki-67 was becoming very, very important at the time. And he asked me where the Ki-67 report was mentioned. I said, it was on the 3rd page, and you can find the Ki-67. Then he goes like, I do look at the PATH report, only the first 2 lines. Fortunately, he has retired, and that's good for all of us. But it's how things, it also kind of reflects on how things have changed and what becomes important. The patients are asking questions as well. So everyone knows if a patient is diagnosed with a breast cancer, she knows what her biomarkers are. The power of Google, I would say, and the cancer awareness among women. So, and we do the immunohistochemistry, which is the HER2, and we do the FISH testing. I used to interpret the FISH results, but we do send it out because of I do not have time for that anymore. Next slide, please. So again, every breast cancer patient, there are many genomic testings, and most popular ones that we get requests for the Oncotype DX. It is marketed by Genomic Health prior, but Exact Sciences is the one from our California-based company. And so this is the most popular genomic testing that's being requested by the oncologists and the surgeons and everyone. But as we have a saying here in pathology that the oncologists love numbers, okay, so scores, that's what they want to look at. So a recurrence score is something that tells you, it gives you a rundown of the distant recurrence, and also are the patients eligible for chemotherapy. So that's most important, right? So first thing, a patient comes and she hears from the radiologist that she has cancer. Am I going to get chemotherapy? Am I going to lose my hair? All these questions do come, and it's very emotional aspect for the patient as well. So then comes the MammaPrint, is also another genomic testing, has a different way of looking at it. The Oncotype DX looks at 21 gene panel, and the MammaPrint looks at 70 gene panel. So this is, again, a lot of information, but everything comes down to the recurrence and the decision of making a chemotherapy decision. So next slide, please. A third scenario, 40-year-old woman with 22.8 centimeter right upper inner quadrant breast mass. So what do you see on a huge mass in a young woman? And also I said 40-year-old, but we do have patients who are 35, 32, and much younger patients. And so on the histology, the striking part of the cancer is the tumor infiltrating lymphocytes called the TILs. TILS has been a huge research aspect of TILS, is that these young patients, genetically prone, triple negative breast cancers, pretty aggressive. And so some of the papers, when you look at, it gives a protective function of these patients' cancers, and they do respond to the chemotherapy, and particularly in the subset of patients. Next slide, please. So I have put down immunotherapy is something that's evolving for the triple negative breast cancers, both in the adjuvant setting and the metastatic setting as well. I do have our clinical trials data from 2022. You can see how many phase 1, phase 2 different trials have been here with the IO agents. And particularly now, as you go into 2025, the phases might have changed a lot. So this is from our lab, PD-L1 testing slide. And this is being requested by the cancer care team, both in the adjuvant setting as well as I said, the metastatic setting as well. But when it comes to our laboratories, there are many, many problems, and you need to, I wouldn't say problems, I would say challenges with the PD-L1 testing. We have to be very careful with the commercially available assays. You need to particularly have the CDX type of the assay, and methodology with validation is like the most important thing. Tissue sampling, and particularly when you have the metastatic setting, patients have cancers within the bone when we get these bony samples. So then again, the question is that what's the use of AI in reporting these biomarkers? So it's still up in the air. So next slide, please. So one of the other areas, as the cancer rates are increasing worldwide, and also for us here, head and neck cancers have been on the rise. 75-year-old with vocal cord mass biopsy. And one of the most common, most prevalent biomarker that's being done in the laboratories is the P16. P16 biomarker is a surrogate marker for high-risk HPV status. And also the block-like staining pattern, the P16 of the tumor, kind of tells us that it has a better prognosis and better response to therapies as well. We do get requests for immunotherapy. And as of last week, the NCCN guidelines for the immunotherapy have for the head and neck has changed a little bit. And now immunotherapy is the first line for metastatic or the recurrent cancers of the head and neck. We do get requests for HER2 testing, and the next one, particularly next-gen sequencing testing as well, particularly in these patients who have pretty aggressive cancers. Next slide, please. So from the biopsy received to the final report, the clinical workflows in current oncology hugely relies on predictive and prognostic molecular biomarkers. Growing number of these complex biomarkers tends to increase the cost and the time of decision making. This is pretty challenging for us as we head towards this personalized medicine and the increasing number of the biomarkers. We have to do the validation and also keeping the costs in mind, and reimbursements and all that stuff do play a part for us. And also expertise, which is a big thing. Challenges in the routine practice. I have seen it's no longer dependent on the workflows that are linear and straightforward. What we have right now are complex branching and flowcharts. So our work has become much more complicated from the moment you step into your office. You get emails, everything, as the patients are becoming more and more aware of what they have, and Google searches and everything. And in this, I need to stop a little bit because Dr. Brian Lynn, he is a Stanford professor, recently has been in the news because he has a stage 4 lung cancer. And he has been promoting that in terms of stage 4, but he has been taking the therapies, but his talks have been on the biomarkers for lung testing in Asian patients. And so it's opening up by these non-physicians a lot of news, and the doctors have to deal with it on have this biomarker being tested, in terms of prognosis or in terms of any in the treatment decision making as well. So that becomes rather complex for us, and the patients are like send emails to us to the medical charts like, I need to speak with a pathologist, I need to interpret this report. So there are many things that are happening, and on the other side, the deep learning and the artificial intelligence development has contributed particularly to the field of radiology, and we are extrapolating those tools to see if the routine clinical practice in pathology and cancer care can be changed. Next sentence, please. Next slide. So I like this terminology called the genomic workspace. That's where we are heading towards. Digital pathology has revolutionized how pathology is used to diagnose cancer, and it definitely has opened up opportunities for research as well. The whole concept of digital environment has facilitated the integration analysis of the genomic data from traditional pathology findings, so enabling us to have a more precise diagnosis, prognosis, and treatment decision. I have many people asking me, is it the AI going to replace anything? And I do believe and also say that at this point, from the medical standpoint, AI is not going to replace anything. It's going to facilitate much better diagnostic stuff for us. And particularly in terms of cancer care, this whole genomic data, I believe, is going to populate into your pathology reports, and it definitely contributes to your prognosis and your treatment decision making much better. Next sentence, next slide, please. Next slide, if you don't mind. So I do not have a crystal ball right now. As people ask me what is going to happen, but I see the changes coming through. We are implementing digital pathology right now and testing the platforms. I had the chance to test some of these AI platforms in our national conferences in the last 2 years, but definitely can improve the efficiency, enable the AI integration, and it's definitely or potentially change where you are on the side of it, that the cancer diagnostic. So I am going to be taking all the questions at the end of the session from the chat, definitely. And next slide, please. So these are some of the references. Next sentence, next slide. So thank you. And if you have any further questions that I do not answer in the sessions, please connect with me. I'm on the social media, LinkedIn, Twitter. So a spring day in Bay Area and San Francisco. Next sentence, please. So next slide, please. So I say that it's the entire cancer care is not done through one person. It's a team effort. And that's what we are at the Team Center. And we do have a very nice organization with the radiologists to surgeons to pathologists, radiation oncologists, and everyone. So I'm lucky to be part of this, and we take care of our patients very well. So thank you very much. And I am going to be giving the podium to Dr. Dhara, who is going to be talking about very interesting stuff of how the implementation of AI will be. And thank you very much.
Yeah, thanks, Dr. Mamatha. And let's see if I can match your... one of the things that I was a little apprehensive, let me see if I can, give me 1 second, this work. There you go, right? So you can see my screen, right?
Yes, yeah.
Yes, we can.
Okay, cool, thank you. So one of the things that I'm obviously learning a lot here, and this is not my area. So my point, the one thing that I wanted to do is kind of paint a broad picture that's not more for me to pivot than actually trying to classify the whole area. Just making sure my goal in the next 20-25 minutes is actually to take some very basic things and see what, when you are looking at AI, what do you need to look at when you're actually developing this thing, or when you're collaborating with people, what do you do? And with some examples, I wanted to show. But this is very broad. I think this is a little different, a slightly different dimension than what Dr. Mamatha has discussed, and hopefully little. I know it is a little away from a lot of you, but hopefully it makes sense. Okay, so the first thing is a lot of the initial things, tumor detection, the subtyping or the grading, a lot of these things come under a broad sense of image analysis. So so this kind of training, if you look at leave out AI, I mean, even if I'm looking at it as a human intelligence, right? So it's more of processing the huge amount of the data, if I understand this right. So the whole slide imaging is massive. So somebody ought to do the data. There's an engineering aspect to it, which is how you process that kind of big data and everything. That leave the engineering aspect, even if you leave that away, and the essence of what is happening, the task, the actual task that is happening, there is image analysis. So you kind of mark that this is a tumor cells, this is not the tumor cells, or this is how it is spreading, and this is how what kind of subtyping it is, or what kind of grade it is, and all that, right? So there's another. I'm not claiming this to be any scientific. I'm just putting this in these buckets for me to make it easier. Okay, so this whole thing of personalized therapy, where you're actually seeing how the response is. You actually evaluate this in the response. Now you're trying to form clusters within the response, whether it's they're going together, similar people having the similar kind of response. Can I apply this to a new person with a similar characteristics, kind of a thing? And in that sense, you can actually predict some of the stuff, the survival rates, the mutation, the recurrence, these kind of things. I'm not claiming. There are a lot of studies. I did look at a whole bunch of literature. There's tremendous work going on. There is no definitive work yet in some of these things. Obviously, as you know, this is a huge field. But what I want to highlight is this is more than image analysis. There's more image analysis predictive power. So they bring other things into this. Okay, and then there is whole advancement of this whole field. That means you're actually going and you're trying to see how genes, how they can morph, how can they do, can I identify new biomarkers, because I understand the biology of it a little more. I understand and see, can I look for patterns? Can AI look for patterns? So it is a lot of spatial, temporal patterns within the intuition that you bring in with years of knowledge into building an AI system. So it's not just image analysis is your workhorse. And that goes into workflows, and I think it's in especially in radiology and in this area, that is a very well. I wouldn't say it's a done problem, but it's very close to a problem that is improving efficiency. Whether it's part of workflows or not, depends on the adaptation of it. But a few good problems there are actually at least are part of workflows, or at least can be in the near future. The rest is all a lot of work has to happen. The third part is where you're actually not only advancing thing, but you're also making a hedge on, or kind of getting your hypothesis using AI, or hypothesis using your understanding of the biology or the cell, where the patterns, what you've seen so far, and then bringing it together. So what am I trying to say here? I'm trying to say is AI isn't a monolithic thing. So when you talk about AI in digital pathology or anywhere, or radiology or anywhere, it is not a monolithic thing. There is different techniques. There are different things that you use, and there are different tasks. So how do I break it up? How do I break it up and see? So when I'm evaluating a system, or when I'm building a system, or when I have a hunch that I've seen these kind of patients, like this kind of thing, so can I go and look for that in my the corresponding histopathology, or whatever you look, the markers that you look at, or you want to detect new markers. So I'll just pivot into, there's a quick overview of AI. I mean, I don't think that is necessary here. I'll come back, I know, to this, but I think it will disrupt the flow. So I hope it's okay if I skip this. Okay, so some basic tenets of AI is the three basic tenets of AI: where your data is coming, what is the language, what is the language of your expression. Okay, I'll explain each of those. Okay, and explain each of those, and I explain how I approach a problem, and I show some examples of it. That's all I'm going to do. I'm not going to talk about your area because that's huge, and I'm reading so much about it for the last few years, and I decided to stay away from it because there is so much happening there, and wonderful work. But I think very phenomenal, like I said, from image analysis to trying to cluster kind of patients, and then do also but core science. From a core science with bringing the intuitions into that, and then AI is actually, in some sense, AI is a new accelerator for science and engineering, right? We all know that. So this is tremendously used in this area. But anyway, the three tenets, basic tenets. One is the data. Obviously, you all know. I'm going to talk about it a little bit. And what is the abstraction? What is the computational abstraction you're picking if you're solving a problem? So there is three areas of problems that I said, right? So what is the computational abstraction, and what kind of algorithm, what kind of task are we doing? Are we doing a simple classification task or an image analysis task, or am I trying to go generate a hypothesis because I've seen so many of these patients? Am I doing a generative thing there, or I'm actually doing a clustering of similar patients before, and I'm trying to predict the survival rate, or predict the reactions, or predict the care, things like that, right? So a simple example of that would be like this, right? So here, if you take an image, and if you look at it, the way there's a whole bunch of the data, the computational abstraction of this image is a multi-dimensional, three-dimensional in this case, pixel. Each pixel is represented in three colors. That's the abstraction there. And then there's a sequence to it. So what's happening here is, so I'll just use this simple example to lay out what I'm laying out, okay? So the input to the whole AI system would be, this abstraction. That's why the computational abstraction is very important. So this is a simple image analysis task, right? So it's taking each pixel, and then the color of each pixel in these three gradients. Each one is from 0 to 256, right? So, and then as you go in the layers, it's trying to find out, what is next to it, what are the edges, what are the contours, what are the things. So each layer, it's trying to find out a little bigger shape, and little bigger shape. And then finally, it identifies a car or a person or an animal. Okay, I'm not going to go into details because that's a thing that you don't do it in 20-25 minutes, or attempt to do in 20-25 minutes. But essentially what you're doing is, if I can wave my hands, and you allow me wave my hands here, I'm learning the weights in each of these layers. When I say AI system is learning, what it's learning is how much weight should I give for this pixel, the blue pixel, the red pixel, and the green pixel, kind of a thing, right? And then how do I combine adjacent pixels together to form a little better abstraction of an edge, and then of a nose, of a face, and then identify the face, right? So that's how things work. So that's why data representation is extremely important. Don't worry about the details there. And then the abstraction, how you represent this, how you represent an image. A lot of things is done for you. For the simple image analysis of your whole slide imaging, whether it's a tumor cell or not, you identify, and it does it because it comes into the classic cases. But if you're solving another problem, you're solving the mutations, solving how the nucleus, the thing is affecting nucleus, and any changes in there, that's when you stop back and think and say, is it a better abstraction to give me better results? Okay, and then what the task is. So in this case, what is the data? This applies to your image data, your text data, your sequence data. There are a lot of techniques that use, and this is used for image classification, speech, NLP, all kinds of things. Okay, so first what I want to do is I want to look at each one of these. So I want to look at first the data. When I'm picking my data, what should it be? What should I watch out? When I'm picking my abstractions, what should I bring in, and what are kind of tasks that I need to do? Okay, quickly I'll go. There's this whole thing. What are we learning here is called the representation learning. That means I'm learning a representation. In this case, I'm learning the representation that this image is a person. And if you look at some of the things that Dr. Mamatha has talked. She's trying to learn the biomarker representation. She's trying to learn, or not she, but in the field, right? She's expressing that, right? So that is where this whole concept of trying to learn the representation that you want, or generate the representation that you have seen across a set of patients, or a set of people, or a cluster that you think is actually a biomarker. Actually, you can generate those kinds of things. I know I'm waving my hands in front of experts here, but I'm trying to bring that into my domain so that I can talk a little more, more honesty. So now the biggest assumption for all this is the data is IID. What is IID? I'll tell you if you're already not familiar. Okay, the biggest thing is the data should be independent and identically distributed. So this is where a lot of things will fail. So if you do a coin toss, the previous toss and this toss is completely independent. So it's completely independent, right? So you look at one dog, another dog, those two dogs are no relation, right? So they're independent, that's fine. But the stock price of today is dependent on the stock price of yesterday. So that's a dependent. So you cannot use that. You understand that is the nature of the data. So the identically distributed, this is extremely, extremely important for some of the medical stuff that I have done. Of course, not in the pathology space, but in other spaces. I'll talk to you about it. And the reason is because I've seen papers as we're going over in the last week in the digital pathology space with AI, don't even mention that, and they're using some sort of federated learning. So that is where I feel I need to bring this up. So again, that means if you're taking images of dogs or you're doing anything, the data has to be in a very identical conditions. Otherwise, you have to use different techniques. You cannot use a standard technique. There's a different techniques that you use from an AI or ML perspective. So whenever you talk about data, just make sure that you have, you're talking about, watch out for if it is independent and identically distributed. That means each data piece is independent and it's not, and the distribution as a whole of the data is actually, you're combining two sets of data. Make sure you're not combining the different distributions, that the distributions are the same. Okay, what if they're not distributed? Which is very fair, very common, because what if they're not, identically distributed? For example, I'll give a simpler example, which I can relate well. So if you take the high school scores of math across a city, okay, I'll come back to that example again. It's true for in this practice, in the healthcare practice as well. But there is a correlation. Let's say there's an math exam in December. There's a math exam in May. So one of the exams is tougher. One of the exams is easier. So there's an uplift of scores in the first. The scores are going to go down. But the range of the scores that go down depends on how good the school is. And there's a pattern to it. There's a distribution is different. The good schools, maybe it doesn't go down as much, but the bad school, it goes very low, right? So you got to understand this hierarchy, even if you're combining, and you want to do for the entire city, you want to do some sort of modeling. Now you cannot just club all those things. You cannot bring all those data together and say, this is the same school district. These are the same schools, or say same, city. I can just bring them together and then do this, boom, done. No, you cannot. There's a hierarchy to that because there's a local influence. And exam is a common thing for both of them. So you cannot just take two different models also. You have to bring them together. So there is a hierarchical nature to this. I'll explain with an example on how we dealt with it. Okay. There's the most other important thing that you need to. I thought, though I haven't explored when I was reading, especially in the genomic space that Dr. Mamatha was talking in the end. There's a huge amount of relational among the data things that is happening. So what you're observing there, from a biology perspective, they're related. So if you can bring that abstraction into the digital, into the how you represent the data, then learning from that becomes much more fruitful. So you're much closer to your your results, much closer to what you want to do, your hypothesis. Okay, so I don't think I have an example of that in this, but I can Yeah, but maybe I do. I don't know. Anyway, so the federated data, so typically what happens is federated learning. I mean, I saw federated learning is something like this, where if you see there are 4 different centers, health centers there, they don't want to share the data. What they do is they kind of one way of, there are many ways of doing this. I'm just simplifying it. One way is they do the models locally, but they transfer the weights of the models to the central location. So that central location learns from everything. This is all fine, as long as the data is IID across all 4 of them. If the distribution of the data is different, they might be independent, which is okay. I think in this space, independent is not such a thing, except the problem that you're taking, maybe there is a mutation, then that's dependent. Let's not go there. But the biggest thing that I wanted to clarify there is when you do federation there, that the influence of in the central, I mean, you have to be very careful on how you're bringing them. Are you bringing them hierarchically, which may be okay? You cannot just bring the weights and then say, okay, I'm going to learn the central one, as if all the 4 are equally identical kind of data distribution. Probably not, because a lot of healthcare patients that come to that center maybe have a certain distribution, certain demographics to them. So maybe that'll result in anything. That's where I'm making conjecture there, but like a school, right? So now the one that I was talking about is like, if you see a relation, if I'm looking at some biology and then say, look, I don't want this to be a plain text sequence kind of a thing. I know they're related. I know this molecule is going to affect that, and that molecule is going to affect that, or think that the relation from a chemical sense or a chemistry sense or from a biological sense, the interaction of the molecule. So you have to represent that into something called a graph representation, and then you can learn from the graph representation. This is becoming very, very popular in this area, and it has its challenges. But this is for tasks that are very, very advanced in some of the tasks. So the plain text is like this, like a linear thing, that each word is, think of the red box, the green box is a word. So it is a sequential thing. That's how it's learned. I'm sorry. The images are these dimensions that I talked about, and each of the dot is a 3-dimensional thing, red, green, blue, the pixel values. And that's how, but then you can build a network of how if you look at the histology image, or and then you say, they're not flat like that. There is a relation. I know the relation. And for the task that I'm looking at, that relation is very important. So you do that, and you actually do learning on that network, and not on this flat image, or the image that you see. So you extract certain things, and then you do that. So again, another way of looking at it is this. The left-hand side is showing you the flat image of how you view images. There's a tumor. This is in the fundus. So you look at the tumor, you identify the tumor. This is good enough for the task. You don't need any relations. You look at the image analysis, and the data representation and the computational abstraction there is. Each pixel has a color. I look at the changes in the color, I look at the contours, I train on this, and then I know this is a tumor. Boom, I identify, I know the space, I can compute the area. On the other hand, if I'm looking at some sort of gene, so there's a pretty standard way of building that this gene A is affecting this protein, and that the protein is doing morphing into this, and then this whole gene A, there's an activation function and all this. If you want to learn something in which, for example, you want to see if there is a translation happening, or you want to predict a translation, you want things like that. So this is the kind of data abstraction that you get. Not that my whole goal is to show you that there is AI is not, just I'm trying to put out different aspects of AI that you should at least ask questions when you're collaborating or when you're evaluating. What is the data model? What is the computational abstraction there? And then what is the task that it's doing? Typically, I see most of it is, what's your specificity, what's your sensitivity? Those are the things that people worry about. But you need to first, talk about these things as well, which is very important. Okay, so like I said, now going to tasks. Let's say if I represent everything in a graph, that I can do many things here. I can do a graph classification. That means I'm not worried about anything else. I'm just saying this whole. Think of this not as a graph. Any representation. It can be an image representation. It can be text representation. It can be graph representation. Whatever it is. I'm just saying that, does it have a tumor or not? true or false. That's simple classification. Or I'm trying to see this particular node is actually affecting or changing, or that's a node classification I can do, or I can predict a link. That means it's not there today. As things are moving in the graph, I can predict that this is going to happen. So there are different tasks for AI to pick, and each one has a different algorithm, different loss function, different the way you compute that. The way you compute the weights is different. So the way you frame the problem is different. So it's not one monolithic AI that's out there and doing things. Most of the thing that you hear is on the top one, where you mark things true or false, or you mark things, this is a tumor, this is not the tumor cells, non-tumor cells, or this, that, or or subtyping, or multi-label classification, and then that's it. That is why there is a lot of buzz on that. But there's a lot of good work happening in other areas that I was talking about. Okay. So I'll just take one slide and talk about Gen AI, and if this doesn't make sense to you, please ignore. But the reason I say is because there's so much talk about Gen AI, so I thought I'll put something. So typically, the classic AI, which I haven't gone through in my initial slide, also the slide I skipped, is pretty much discriminative. That means you have a bunch of features, the X features. You're trying to that there is Y happened in the past, and then you are trying to get your new features, and then trying to predict what the Y value is. That's essentially what is happening there. Okay, so how do you do that? You kind of search what is a function that fits in the space. The best function that fits with highest accuracy and all that stuff is what you do. Whether you're identifying an image with a tumor or your other things, that's what is happening. Okay, don't go too much into it. I'm just wanted to highlight one point. On the generative AI, what is happening is, you have both your X and Y, and you're trying to, and you have a desired output. Okay, the reason I'm saying this, I have something that I want to say profound after the, or not least, something I want to state, and then that's why I'm taking the pain of explaining this. I know I'm being very high level here, but there's a desired output. I'm not predicting the output. There's a desired output that I want, and I'm going to go and say, what is the best joint probability? What is X that I need to fix, or I need to pick? Okay, another example would be, let's say you're cooking, right? So there's a bunch of, for the discriminative case, if I tell there's tomatoes which are like have certain characteristics, there is onions that have certain characteristics, there is like salt, pepper, whatever, right? And then I say, if you put these things, this is the kind of dish that you get out of that. Okay, the taste of it would be tangy, whatever. And then I do that. And then I say, okay, I'm giving you a bunch of ingredients. Tell me what is the taste. That's what the first one is. Okay, so it's looking at the previous, and then a good mix of what is the closest X to that, or vector of X to that. And then I say, oh, then it's tangy, it's going to be a little sour, it's going to be this, and I'm going to predict that. It's very simple, not simple. That itself is complicated, but that's what it does. But what generative AI does is, I'd say, I don't want all that stuff. I'm giving ingredients. I'm giving you previous history. Now, I want a dish that tastes like this. Go figure out the ingredients. So it's going to generate the ingredients by doing conditional probability, joint probability between both of this. So the reason I tell you is this, because the way science is approached has changed because of that. Because this gives us the hypothesis. You know your desired output a lot of times. What is your desired outcome? So if I'm creating, for example, a new material, I know what kind of material I want. I want a material that is very light, but the tensile strength has to be strong, and then I give it a lot of history of what kind of materials have that, what kind of mix of that, what kind of alloys have that, and all that stuff. So it's going to say, these are the 10 candidates, go try it out. Okay, so the way science is accelerated is also because of this. The top one also happens a lot. The image analysis is the first one, but some of the things that you see is also can happen. The hypothesis is generated, and the rest of the process is as rigorous as you do before, as anybody does before. So when you do a new material or a new biomarker by this, you actually do all the things that you do in a regular way. Okay, so that's the point that I want to highlight is like you start from desired output and then go back and figure out what is the best X for this. Okay, So that is slightly different way of thinking, and maybe already do that. But so quickly, I know if I'm over time, just let me know. But I have a few examples. So this one is something that I've worked, and I'll just take a minute on each of these slides. The data representation that we had was from patients from successive visits. I don't know why it is not. There it is. Okay. So from success, this is a fundus image. And it's showing your posterior, anterior, corneal, and sagittal curvatures, and the elevation and thickness, the anterior and the corneal thickness, and this is for keratoconus, which is a disease for a lot of it is probably you all know this for teenagers. But the idea here is there is this diopter. The standard practice to see the diopter difference between visits. If it is anything greater than 1, then they say, okay, this keratoconus is progressive, and they do some sort of clinical intervention based on that. Okay, but from a biological sense, everybody knows that the signs are there much earlier of the progression. So what we went out to see is, we say, okay, can I identify that? Can I identify? So we have to go through a whole bunch of, so we take 2 of these images. So, and the corresponding images we compare, and then see what the difference is. So the way we had to take the data is we had to be very careful on successive visits. The successive visits are within a date range, then it comes under the same distribution. Otherwise, don't. So that means, though their successive visit, somebody is very prompt and they come every 6 months, that's one thing, but somebody comes after 2.5 years, their progression is much higher. So I cannot, there's no the latent thing that I cannot capture from there. So we did that, and our results show that there is certainly something that we can identify much earlier, several months earlier. But that result is not what I'm talking about. I'm talking about how we represented a simple image analysis here, but how we broke it down, make sure the data is appropriate for that, and then build different model for each of those. So we didn't build one big model. We built different models so that we are not trying to. The holy grail is to build a big model that does everything. Okay, unfortunately, that's not. The world, like I said, the data, the ID, certain aspects of the data doesn't let you do that sometimes. Okay, another thing, I'm going to go into a slightly different thing, where there's something that I've worked on where you have these macro scenarios. There's these macro variables of pricing, house pricing, home interest rates, GDPs, consumer price index, whole bunch of things are there. Okay, when they change, typically when you're trying to lend to businesses, you will see how the business will do, not how good their books are, but how the industry does. Even if it is a wonderful business, if the industry doesn't do well, it's going to go down. So you need to have an evaluation for 5 years. The problem here is, when I'm perturbing some of the macro variables going forward, so that means today, as we sit with all the tariffs or whatever it is, right? So I'm going to predict that GDP is going to go down for the next 2 to 3 years, and then the consumer confidence is going to go down. The interest rates are going to be stable or whatever it is. There's Oxford, there's S&P, there is other places that predict the macros. The problem here is I cannot treat the sectors differently because the sectors are themselves dependent on each other. If one sector goes down, there is a hierarchy. So as you can read from the red thing that the Brent barrel price goes by up 1%, it's going to increase the transportation revenue. If the transportation goes in, then the groceries go up, the airlines go up, the car sales go down. So there's a hierarchical thing. So we use something as a prior. We clustered related things and used a hierarchical learning for that, Bayesian models as a prior. So all I wanted to point out here is you look at your data very carefully. You look at your clusters very carefully. You look at tasks very carefully, and then decide on what you want to do. Even when you're evaluating the system, you need to ask these questions. I think this part you can very well. Some other thing. This part I myself haven't done this completely. I was advising this company, so I didn't do this. I just disclaimer on that. So I was advising them on one small piece where they wanted to pick the gRNAs for editing, and they're obviously they don't need to be off target. And one of the thing they want to add is they want to not only do just pick up from the literature and what the literature says the probabilities are. They want to get the best match for the editing, but they also want to add some of the epigenetic characteristics to it. Okay, and see how that is going to go, and that's where this one does, and this is again the coming back to the three things. How you represent your DNA, we all know that though it is a three-dimensional thing, it's represented as a two-dimensional thing. That's where your epigenetics is lost. Some of the epigenetic characteristics are lost, so that's where they're bringing the epigenetics into the mix for the algorithm. Otherwise, so there's a nucleotide here and then there's one here, but in reality they may be very close, and that has an effect in a three-dimensional space, right? So that's why they're bringing the regulatory gene may be very closer to where it is what it's regulating than in a two-dimensional sequence. So that's why the hypothesis here is they understand that and they say let's bring those elements of the three-dimensional into this other properties, and then I will learn from that. So this is one of the things that I was talking about when you're looking at these two-dimensional slides. You got to, if you understand that there is more to it, you got to bring in other elements. So one last thing that I'll talk about is which is what we did. This is for retinoblastoma. So what we did is we wanted to grade this, right? We wanted to do A, B, C, D, E. So we didn't want a huge one image analysis to do this. And because we want to extract the features that the doctors think, the physicians were telling, these are the features that make them like the grading. So we built different algorithms for each of those. So we built an algorithm for tumor, we built an algorithm for optical disc, we built an algorithm for identifying the seeds, the dispersion of the seeds, and then different algorithms for blood vessels. Are they over the tumor or under the tumor? And the hemorrhage, the area of the hemorrhage. So when we built a bunch of features and then used a standard classic ML algorithm to actually classify them. So you can break up the problem down into multiple. So it comes under AI, but there's so much AI going on, different pieces, but it's very easy for the doctors to explain this because the features, extraction of the features, you're using deep learning, which is kind of a black box in some sense, but the decision making is not a black box. It's very clear what is extracted. Okay, so the point here is we didn't want to represent them as images, we want to represent them as features, but within each feature, we want to do an AI algorithm that represent in each different way. The blood vessels, we were just looking at the pixelization of them and then identifying them as a computing the areas and other things of that. So anyway, so the point again. There again, what we did was we did from LV Prasad. I collaborated with them, and once after we did that, then there is a request, obviously, even after the publication with Wilsai Hospital in Philly. So we tried our algorithms. Boom, 2 or 3 of them did not work. Clearly, because I was telling, right, that the data set is completely different, the distribution, the way we are reviewing, right? So, and when we saw, obviously, the fundus image is completely different. The way we represent the data for extracting a tumor is pixelized, right? And the pixel characteristic has changed because the fundus is not like an Indian fundus there. So then we had to retrain them, and we did a bunch of things, and then that's a different model. So the thing that I want to highlight here is we had to redo. Some of the things worked because the assumption of the data is not that there. That is fine. But when the assumption, the way we're representing the data, that assumption is broken, we had to redo the whole thing. Okay, so back to basics. I hope I kind of gave an overview of, when you look at data, you need to understand what the distribution is. I don't think you need to worry too much about the independence of the data because you already have the thing, but the distribution when you're bringing together, and then what is the acquisition tool? Are they using the same thing? And that actually has an impact on the distribution as well, on the quality of the abstract representation that you're going to do eventually. If there are any relations within the data that as a domain expert, as a knowledge person that you're going to bring in, you have to bring in then, because then the task that you can define is much more impactful and much more core. You can do a lot more stuff, and then you can choose your AI and algorithms. That's all I have. Yeah, hope this gives you a key thing is, like I said, right? AI is not a monolithic thing. You need to look at these kinds of things when you're doing this. Image analysis is it's the reason why it's working well is because it's a very well solved problem from an AI perspective, but other problems are not. When you encounter them, question all these things. So you need to understand all these things, and that is where I see a big role in a lot of radiologists, pathologists, bringing years and years of knowledge and study and expertise that they have into this, into understanding and interpreting this. When they look at a score, anything can give a score, right? So when you look at a score, you need to understand these kinds of things. I'll stop there and see.
So,
Hand it
Dr.
over to
Dhara, I
Dr.
just
Mamatha.
want to address the audience as well. Reason I wanted you to speak on this platform and many others coming up is that, the medicine is changing fast, and cancer care particularly is changing as cancer rates are increasing across the world. And not anymore the patient comes in and rely on the doctor to say this is what it is, give a Tylenol. That's not what the medicine is going to be. The patient is going to come to you and ask you, what does this biomarker mean to me? Okay, so those are the things that the doctors are going to be facing. And particularly my kid is graduating, but I tell him as well, these are going to be the genomic medicine application doctors that are going to be the new generation doctors. And they do need to know what's going on, the basic stuff, before they can talk to the patient about what is my EGFR mutation risk. Okay, so I don't think any doctor can explain that to the patient, okay, unless you know about all this stuff. So I think, to me, the awareness among the physician world has to change. The whole concepts have to change, and you need to redirect yourself to be thinking, because it's a huge emotional aspect to it. Okay, cancer diagnosis, the sticker, okay, cancer. So I think that's where you try to simplify for us. Thank God we have people like you to take care of a lot of stuff. And we, on the other side, we do take care of other things as well. So thank you so much. This is really a great talk. Okay, so I would take some questions right now. I know there are a lot of people asking. So Akila, do you want me to start off with the questions, or how do you want to do this?
Shall I read the questions in the comment box
Yes,
first,
please.
ma'am?
Yeah.
So first, Mr. Kundappa has asked, can you please talk more about P16 and testing for lung or other cancers?
That's a great question. My story with P16 and cervical cancer dates back again to 15 years. I worked with the P16 biomarker has been developed in Germany in a laboratory, a small company called MTM Labs. And I did work with the laboratory people in developing the P16 biomarker for cervical cancer with a high-risk HPV status. So fast forward, it was Dr. Rüdiger from Germany. And if you look at the data on published data from them, then the P16 was bought by Roche company, the biomarker. So fast forward, when I look at the extrapolation of the P16 into the head and neck cancers, as I mentioned, P16 is definitely a surrogate marker that we are using in our practice, particularly for any head and neck cancers, for bladder cancers as a diagnostic marker, and for cervical cancers, obviously, for the high-risk HPV status association, and for any gynecological malignancies such as vulvar, cervical, vaginal cancers as well. So so far, P16, we don't have a targeted therapy for P16, but it is used across the board as a prognostic and a diagnostic marker. Next question, please.
He has another question, which is, what kind of targeted therapies are available for SCLC in the clinic? Are there any early stage detection methods?
I'm sorry, what's the word there?
SCLC, I think it's small cell lung cancer.
Small cell lung cancer. Yeah.
Small
Also, as of now, for the small cell cancers, we are not doing much. It's a platinum-based chemotherapy still. Unfortunately, there's a lot going on in the non-small cell carcinomas because we are having an increased number of patients who are non-smokers having advanced stage cancers as well. So, so far, we are doing the routine EGFR, the biomarkers, but immunotherapy is an option for the PD-L1 testing. So I do not have any new data on the non-small, the small cell carcinomas. So
his next question is he's asked if there are any suggestions for early career researchers, and he's also additionally asked, can AI detect metastatic tumors that are obscured by physiological background uptake in PET-CT images?
Okay, so I would answer the part one. Any interest for the early researchers?
Any suggestions? What?
Suggestions. Okay. So in order to understand and do research, I want to take you back to our area of the whole cancer area. Okay. So I will be meeting a nurse who is diagnosed first time with breast cancer next week. Okay. So she wants to come and talk to me about her report, her thing, and everything. So it's a journey. Okay. Cancer is a journey. Okay. So when you talk about the cancer journey, it starts from detection to diagnosis, treatment, and the post-treatment care. So where we, and there's a huge component that we do not talk about is the prevention. But there are certain cancers, or majority of the cancers, there's no prevention, but there are other cancers where we have the prevention part. So I think to me, a cancer researcher who wants to start off where they want to see is more in favor of the diagnostics and also metastatic setting where do not have options, much options. So these are the two areas that I would truly focus on. I hope I answered your question. And the second part of the question is that, I'm sorry, can you repeat the second part? Yeah.
Can AI detect metastatic tumors that are obscured by physiological background uptake in PET-CT images?
So in order to understand the metastatic setting, you need to understand the biology of the cancer. So from the pathology aspect, there are cancers that have the propensity to go to distant organs. So in the distant organ setting, you have the bony areas and the non-bony solid areas. For example, breast cancer, particularly invasive lobular cancers, have the propensity to go to the bone first. And then comes the liver, and you talk about it. Then you have another prostate can go all the way up to the lung as well. So this propensity and the travel of the cancer cells across to the solid organs and the bony areas is a huge area of research. And also there is a test, particularly for the metastatic setting from the Foundation Medicine about the liquid biopsies. And also other companies are also doing that, which are testing the 180 gene panel, looking for the cancer cells in the metastatic setting as well. So I think to me, although the imaging part is can pick up and also miss some of these metastatic settings if the patients are asymptomatic, but I think there are other tests for the liquid biopsies are truly playing a role. And also, I think the AI, I'm not sure, again, I have to roll my dice here again in terms of AI and the metastatic setting. We do not have enough data yet on it, but I would definitely rather bank on some kind of a liquid biopsies. They're testing the isolated tumor cells, but they do have huge problems in terms of what they're picking up in these samples, but definitely an option to evaluate further. So
let me add a few things, right? So on that, so if I want to paint a brush, of course, I'm not the domain expert here, but or anywhere close to that. So anything related to an image, if we can do, if that's part of your operational efficiency, or you need to do a whole bunch of them, and you're going to miss it, an AI system is a very good assistant for you. There's no question about that. Because from an image analysis, problems are very well understood, very well solved, and things like that. But like what Dr. Mamatha is saying, there is another biological and other things. That's where the new models are coming. That's where I was talking about how you represent that. What is your abstraction of representation, the relation between those things, and then you study, and it could give good markers, or it could predict things. It can do other things, absolutely. But actual identification, if it's an image thing, it's my bet would be AI can do that.
Absolutely. And I think you nailed the point, is that the biology of the cancer determines where the cancer is heading towards. Okay. So you will have some hiccups on the way, but I think you need to understand the biology of the cancer itself. And every cancer is different. A breast cancer, prostate, everything is totally different.
Absolutely. So and the first question of the research, and what would I research, right? I mean, obviously I'm not even qualified to even say anything here. But if that question comes to me in the domain that I tell them, pick a domain, work in, and then even though you know AI, it's not going to do anything for you. Okay, pick a domain. I think it would be the other way around for you. You have the domain, you know how personalized care is, where personalized care is heading, where some of the core signs in that biological, what is happening. So if you understand certain aspects of how you can accelerate your discoveries, AI is one of them. Maybe there are other things, but very good diagnostic machinery or whatever it is that you have in your lab, right? So these are the accelerators of science. So if you have those, that is something that I would actually latch onto to do what you want to do your core, improve your personalized care, improve your do new kind of therapies. That's the mix that I would bring, is what my 2 cents.
Yeah. Next question, please.
So, Mr. Raghu Halkar has asked a great case-based explanation of modern pathology workflow by Dr. Mamatha. Nuclear medicine is increasingly involved in therapy. Thyroid, prostate are 2 big areas for us now. I see very little genomics done in these 2 cancers. Thyro-SEQ helps, but done only on FN aspirates. Any new developments in prostate and thyroid cancers?
So I think I saw that you are my neighbor from UCSF. So, but definitely the thyroid testing has moved. Actually, I am very lucky to be part of that thyroid testing development, not directly, but I've been trained at University of Pittsburgh, where Dr. Nikiforov's lab has developed the thyroid testing. And I worked with his wife, Maria Nikiforov, and it's bought by the CBL Labs now. And I think what we are using in our clinical implementation right now is thyroid testing is done particularly in the atypical thyroid lesions right now, but I have seen other institutions using this, the thyroid testing in terms of diagnostic as well as prognostic stuff, and also predicting the recurrence, particularly in the thyroid cancers as well. So as of now, there are 2 companies that are we are using Afirma, which is part of the Bay Area. Actually, it's a company, Bay Area-based company, and Pittsburgh-based company is the thyroid testing. There are many publications. If you would like to review under Dr. Nikiforov, there are versions of thyroid testing, version 1, 2, 3, and 4. And definitely every version of it has been developed and giving more prognostic information regarding that. In terms of prostate care, prostate cancer, we are getting requests from a company called Decipher. I do not know where the company is from. But we do get a lot of requests from our clinicians to send it for Decipher. And particularly the prostate cancer, as you know, the grading is the most important thing. And the highest grade tumor gets sent for genomic testing. And the exact sciences, the oncotype people do have a test from their exact sciences as well for prostate, and I have seen that, and they do give a recurrence score. Again, it's a prediction of a recurrence as well as what you chances of eligibility for chemotherapy and many other things as well. So.
Could I, that's a great explanation, Dr. Mamatha, but could I add something? So I think the question was, why do we test only on, at least at Emory, and Dr. Halker is actually at Emory as well. For thyroid, we do ThyroSeq only on lymph node aspirates or the initial aspirates of a thyroid nodule. We don't send it out on our thyroidectomy specimens, and I don't know if there's a specific reason that it's done on aspirates and not on actual tumor samples. So that's one question. And the other is, thyroid and prostate, not so much prostate, but even for prostate, usually these are slow growing tumors which last for a long time. Does that have to do something with lack of significant genetic testing on these two compared to, say, for example, breast and lung? So those are the two topics that we want to touch upon.
Okay, so let me explain to you that the way ThyroSeq is handled, okay, I would like you to refer to Dr. Zubair Balash, a dear friend of mine, who has been part of the Bethesda classification for thyroid, okay? So you can look under him. Balash is B-A-L-L-C-H. He's at UPenn. They have published a lot of data on the testing, and also Dr. Nikiforov, who has done the molecular stuff. And the practice of ThyroSeq testing is, it's again not standardized across the country. I have seen institutions and small practices and some of the practices which are dominantly labs, particularly on the East Coast, in the New Jersey area where the uropathology is pretty high, labs, they do it in a different way. So the reason why the lymph nodes are being targeted is that patients are already, they know that there is a papillary thyroid carcinoma and has a propensity to go to the lymph nodes, and the treatment changes right away and the stage changes as well. They want to pick up those cells through the ThyroSeq testing, almost using the isolated tumor cells kind of technology. I think probably that's the basis why they are doing it. And like in our institutions, the atypical lesions get sent. And I have seen many of the other labs sending it across the board. So unfortunately, we do not have standard testing for the ThyroSeq. So you will see a lot of difference in practice systems as well.
Yeah, because the things with the tumors is heterogeneity, right? Like we see that markers that the primary and the nodes may have different, and so, but we never see that being discussed in the setting of thyroid at all. So I don't know if an issue with ThyroSeq or not.
It's a great question. Heterogeneity in biomarker testing is hugely published in the breast cancer area. Okay, we do have publications regarding the HER2 testing in modern pathology as well. We did, so the question comes, what's the ideal sample to test as well from the heterogeneity perspective? But thyroid, again, as I say, going back to the biology, certain tumors have the highest heterogeneity compared to the lowest heterogeneity. So probably thyroid is one of the reasons of a lower heterogeneity status. That's one of the reasons that it's not being published as well. And it's not widely prevalent as breast cancer, but I say that, but now I see every cancer. Okay, so that probably is the reason. And for the prostate, let me explain to you again the biology of the prostate. When you are giving a well-differentiated grade 1, 3+3 score, those are the tumors that the oncologists and the surgeons, and they're not touching the tumors, no treatment. But 4, 5, 6, and above, all the scores, they do have highest recurrence rates. So yes, the prostate does recur. and you keep on moving on, the recurrent prostate and stuff like that. So there is definitely high grade biology of prostate cancer. Unfortunately, we do not have, the PSA hasn't been shown, although it's a sensitive marker for men above 50 and also African American origin. We do have some guidelines of testing these patients, but we do not have a proper guidelines for prostate testing. Although some of these Hollywood actors like Ben Stiller, he has promoted this whole screening for prostate cancer, but it didn't go nowhere because the specificity of any screening testing should be really high to really promote a screening testing as well. But I would say you have a baseline PSA about 55 plus years old would not harm you, but at the same time, it's not going to be a huge screening test. So I hope I answered that one. So next question, please.
Next is asked, AI is a powerful tool or weapon. Importance of governance comes from its potentials in wrong hands. Any thoughts how AI pertaining to medicine be available to qualified people? I don't like the idea of control, but I see consequences of lack of gun control.
I'm going to make Dr. Dhara answer the question first, and then I will tell my opinion regarding that.
Yeah, so this is more of a, I think the hypothesis, the core of the question is right. It has to be in the hands of a lot of people, but it has to be in the hands of the qualified people. But again, the explainable AI is one thing that the AI community is trying to, there's a lot of efforts on explainable AI. At least what I feel, I think if you look at the gist of the question, who are the qualified people here? Okay, you need the freedom, but you need some sort of qualification to actually understand that, and then it can be in your hands to interpret it. So the qualification is where you should be able to understand what the data sets are. You should be able to understand what the how the task or the explainable part of the AI is coming from. Those are the things that you understand and how to interpret. For example, the recurrence score, right? That Dr. Mamatha is talking about. How is it computed eventually, right? And this especially becomes very pertinent if you're doing targeted therapy. In a larger ecosystem, it's fine. If you're doing millions of people and then the study of that, and that is all fine. But if you're really looking at targeted study, so yes, it will come into the hands of people. I mean, if you're I really don't know the question there. The thought, just my thoughts are, yes, it will come into the hands of very good physicians, but like any other tool, how judiciously they use and how much awareness they have or how much qualified they are to interpret that is up to them, because they'll obviously correlate with other signals, not just this signal, is what my hope is. I'll stop there and see what Dr. Mamatha has to say.
So I just want to give you an example of how physicians deal with this new changing technology and the molecular testing. I did have an encounter with an Indian oncologist recently who had, both of us have a common patient who has gone from Bay Area to India to get treated for a cancer treatment. So what he did was the molecular testing was run and everything, and this is particularly, this cancer is we're looking for targets for treatment and the prognosis, and the patient's family wants to know how long is my mother or mother-in-law going to live for. Okay, so all these things are huge questions for a family. What he did was he did connect with me almost like a WhatsApp tumor board group thing. And I did have an opportunity to discuss with him regarding the biomarkers and the prognosis and everything like that. So I think, to me, we are particularly in the cancer field. I see cancer field, but I have a lot of buzz going on that people talk about diabetes and inflammation, liver disorders and inflammation. So people are going at the genomic level to talk about what this means to the patient and what it means in the long term as well. So I do know that majority of our doctors are illiterates of what Dr. Dhara has described, and they do not know how to interpret a genomic report. So unfortunately, that's where we are right now. I know it's a strong statement, but I think fast forward, it will change for the new generation of doctors that are emerging out because they are exposed to this genomic world. And to me, it's not, AI is not going to be replacing anything, at least in the near future, but at least it's going to be helpful to the physicians to particularly, I would say it's in the cancer care that we need that to make our lives and our day-to-day work very efficient. That's where I stand. Next question.
Mr. Raman Parashuraman has asked, for emerging biomarkers where good antibodies are not available, is fish-based determination available? NGS can provide information about the presence of a marker, but not precise localization.
So I would say the fish is very standard for certain things, particularly for breast cancers, for HER2 testing, we do use fish. Then the second of, I would say for soft tissue tumors like liposarcomas, there is a fish testing for MDM that we use for. And there are other areas recently for the PIC testing and for phylloides tumors of the breast. So there are certain tumors that fish is definitive for it, but I would not discount an NGS testing, but what we are doing right now with some of these translocation markers, which are definitive for certain tumors in terms of diagnosis or for the prognosis part, what we do is we do the NGS testing and then reflex to a fish testing. So as an adjunct, I would standalone fish testing is not applicable to many of these cancers, sarcomas, and all that stuff. So Dr. Dhara, had any experience with fish testing, cancer care?
No.
Next question, please.
His next question is, can Gen AI be used to understand what kind of benign tumors can potentially turn malignant? I mean, to generate stages through which benign tumors may pass through before becoming malignant when data about intervening stages are not available.
Oh my God, great questions. I will let Dr. Dhara
Yeah.
answer this first, and then I will answer
Yeah.
this.
A couple of things. One is I need to drop off soon, but this is a great question, and then it itself has a good hypothesis, like I was talking about, a good scientific hypothesis, and we can certainly do. I mean, some parts of it, yes. If you understand, if you're you need to. This is where you need to bring in knowledge in, right? So if you understand that the passages has the two ways of doing this. One is you just look at the data and come up with it. Okay, so you don't have any biology, you don't have anything. You just said this is the correlation that I'm seeing, and then this correlation is taking this benign to this malignant thing in these 3 stages. I can break it up and then say stage 1, stage 2, stage 3, and then do some sort of pattern matching and do some correlation. Which one of them go into that stage, which don't? That's one way of doing it. Another way of doing it is actually say, look, I understand the biology of it. I understand the transition of it. I can guide the model and let it learn that from the data. So I would say the second one is much better, is what I feel. Yes, I mean, in some sense, some parts of the question is certainly very valid hypothesis to start a very good project on this. Whether it's the efficacy of it remains to be seen on the data and the stages that I really don't understand myself, because all I know is cancer is way too big to have these stages as very specific, right? So if you can take one particular form and then one particular stages and then see, this is what I want to try it out, I think it's a very good thing to do, is what I would say.
Great, a great response. So from it brings back a huge memory for me, is about our ductal carcinoma in situ, DCIS, in breast cancer. So when you look at from the patient's perspective, a diagnosis of DCIS, it's a carcinoma in situ. any carcinoma in situ, the patient is sitting and the question is that, is this a cancer or no cancer? But you're calling it carcinoma. How is my life going to be for a 40-year-old? I still have life to live. And when am I going, this DCI is going to turn into cancer? So these are all the questions from the patient perspective. We did actually developed a model. Actually, I did work on a prognostic model for DCIs, which I presented at San Antonio Breast Cancer Symposium a long time ago, and with my resident, Jennifer Pekarsik, who's a faculty at University of Pittsburgh. Day and night, we did about 15 biomarkers on 1,000 set case, and we spent a lot of time looking into which ones progress, which ones do not progress. Okay, so right now we have a general consensus data that's floating around that if you have a DCIS, depends on the grade 1, 2, and 3. A 3 would definitely have 80% upstaging in the final diagnosis and stuff like that. That's more of a sampling thing. But the question is that any kind of stuff that we look at, the pre-malignant conditions, okay, is the first question is that on a path report, we need to put in the implications of it. There was a fancy diagnosis of a bladder tumor recently, which is really coming out, a papillary neoplasm with some kind of micropapillary stuff. Reverse polarity is a new terminology from the urology group. But the question is that, what are the implications? The first thing is like, the surgeon looks at you, hey, what does this mean? What's this terminology? What do I do to this patient? Oncologist comes, what do I do to this patient? Okay, so the whole biology again of this is that the studies have shown that it's such a rare condition, it's benign, no recurrence rates and stuff like that. So they do depend on the pathologist to review some of these pre-malignant or no malignancy conditions and to see. But then we have data on some of this stuff. You have a cirrhosis, you know the potential for hepatocellular carcinoma, what are the stages and how long it takes for cirrhosis to turn into a carcinoma in some of the people. And we have cervical cancers like high-grade dysplasias, carcinoma in situ. How long does it take for a carcinoma in situ to develop into a squamous cell carcinoma eventually? So we do have established data. We do not have established data for some of the stuff. So I do not know how far the new technologies are going to help you in terms of these patients. But again, constant surveillance, following the guidelines, and those are the only ways right now to follow up these patients to see when it turns into something significant.
Right. So I think that the core question is if I want to add, you study the patterns, as a practitioner, which is fine, but can it identify the latent ones? Yes, it can, given the data, but somebody ought to see if these correlations as a causation or it's like just a correlation, right? So that the study should be associated with that is what I'm saying. So there's one way is what Dr. Mamatha is saying, you know what this is going to happen, you see in the data, you look at that. Another way is, I don't know, this is a bunch of data, this is what happened. Am I missing anything? Or do I know, and do I not know anything? So you actually get that and then go back and say, what am I seeing here? There's this thing, can I explain this? That happens a lot. That happens a lot with AI because of the big data, because you can look at it, right? And then that is what AI is bringing, a huge thing that, a few, with the lack of time and other things that you cannot see the patterns. I think that is what AI is essentially is accelerating. So I really need to drop off.
Yeah, I think that's what I was saying, that you need to drop off. So I think we'll stop any more questions. A very interesting and involved audience and questions. I appreciate that. Hopefully AI will help streamline. I think Dr. Mamatha showed some timelines about 24 to 48 hours turnaround time. that's very optimistic. In our real world scenario, we see path reports for biomarkers take more than a week sometimes. So I'm hoping AI will streamline those workflows at least and get those results to us sooner. But I think we'll conclude. I think our moderator can conclude, and we can stop here. I appreciate this panel. This was new for us, and it was very interesting and moving. Thank you.
Thank you very much. I really appreciate for staying that long. So, and thank you, Dr. Dhara, for accepting my.
Thank you, Dr. Mamatha. Thank you, Dr. Dhara. It was truly informative, and as a researcher in the life science, I think it has been truly eye-opening as to how we can implement AI in translating all these outputs into the clinical settings.
Yeah,
Thank you
would
once
say
again.
to the audience, use it in good health, any kind of new technology. So,
thank you. Bye.
Bye.
Thank you. Bye.
Thank you. Have a nice day.
Bye, ma'am. Bye, sir.